Welcome back. Thank you for staying with us. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Dr. James Nyikal is the lawmaker representing Seme constituency, a member of the National Assembly's Health Committee, and Dr. Kahura Mundia is the Deputy National Chairperson at the Kenya Medical Practitioners and Dentists Union, KMPDU. Gentlemen, let's now focus our attention on what will kickstart on the 1st of October, that is in about 5 or 6 days' time. And it's going to be the leap that the country will take. Dr. Nyikal, coming to you on this first. And of course, this being enabled by the 4 pieces of legislation, now Acts of Parliament, that will be aiding in the provision of healthcare for the Kenyan people. From your experience as a member of the committee that substantively also had made its contribution towards the 4 Acts of Parliament now, are we ready?
Well, from the presentations that I've seen in the to the committee, I have the impression that we are not quite there yet, as well as I would have liked it if I was making the decision. And we have put this to the ministry because when you say you are shifting from one system to another, the assumption is that you have all things in place so that the shift will be seamless. But what I know, and people will expect that when you go to the new thing which you are telling people is actually a better thing, they will feel better services. Now, the arrangement, a lot of work that has been done is actually being done on the pooling. Mm-hmm. So one is the way they're going to pool the money. That is the difference. Now, if people are shifting from NHIF to SHA, it's not clear to us, even at the committee really, what exactly is going to happen to, say, the staff, the funds that are there. Probably will assume that they'll automatically be there. But more importantly, will the people who are now registered with NHIS automatically get services under SHA, or do people have to register again? And we've asked that question, and the issue we get is that they have to register again. And that, I think, where the bigger problem is. How many people have registered? From what I gather, about 1 million, just over 1 million. Yeah. And so that means, what are you going to do on 2nd? What I presume will happen is this will actually be the start of a very major drive so that we get into the new registration system. But it's not going to be the shift that from now we are totally away from NHIF, yes, and totally in SHA. I don't see that really happening. Yeah. But if it signifies the change, and now we start to move over, whether we have arranged it or not, I know what is going to happen. I know how things happen. We are going to accept some transition arrangement where both are working at the same time. Because otherwise, we may find that we lock out a lot of people, yes, who know they are members of some insurance. It was called NHIF, but now there's a new system called SHA. Yeah. Yeah. So that is where I think we are going to be. I'm not convinced that bang, first, 2nd, everything is SHA, yeah, and things are moving smoothly. Rarely do things work that way.
All right, all right. And Dr. Mundia, here is the case, because the way this is designed as a result of the 4 pieces of the 4 acts of Parliament, it more or less focuses or lays emphasis on the criteria, which is register first, then get service. The assumption in the public domain is that on the 1st of October, if a Kenyan in Kwale County goes to the next medical facility, the expectation is that he or she gets services. But the registration database shows that only 1.9 million Kenyans have registered. I mean, how will this happen then from the 2nd of October? And here are we looking at the problem of readiness that has not been critically addressed by the government.
Well, the many things It's an important, very important subject that we're dealing with. Because we all know that NHIF has been in the country for the last 50 years. And for NHIF to reach where it did, it took a lot of growth to happen. And now that we're introducing a new system, we are yet, most of us, not very aware about it. And that means good money is going to be spent to publicize this new agent. Now, having said that, because they're not ready in my opinion, it's not possible, or it's not even foreseeable that persons will actually appreciate the services that are going to be offered by SHA. Reason being, the providers themselves, most of the public and private facilities, have not been onboarded. And the contracts are yet even to be processed out. The registration, like we say, about 1.9 persons. There are many more Kenyans that require that cover to happen. Mm-hmm. Myself, at all selection of facilities, again, most of the patients, most of the Kenyans have not chosen facilities to be attended to. Again, we look at the benefits tariffs. These are the benefits that the SHA authority has suggested to pay. Mm-hmm. As we get into the date first of the month, there are no monies allocated to SHIF by date first. There are no monies allocated to the emergency fund.
Okay.
And by the time the monies come in, the cases that happen per month or per day, sometimes there are too many, and unless the payments comes, like they suggest now that they'll pay at the end of the quarter. So the system will run on credit between that 1st of October to December. So most of the payments will probably be coming in by December to sustain the system. So they'll hope that they'll make collections between the months of October, November, and December, and use that to compensate the providers. Because if the providers are not compensated, the system will tend to crash. Now, on the benefits issue, I'd want to say, first of all Kenyans will have no dental benefits. And that I want to be on record. SHA does not envision to provide dental services in its first years of operations. That means all Kenyans will have to procure a separate medical cover or a separate dental cover to cover and provide for dental benefits. So the mouth has not been prioritized. Mm-hmm. I don't know why. The providers in that sector have given information toward that issue. They have not been heard. And dental care is very important because the emergencies that are seen in that region, the cancers around the mouth, they will not be screened. The infections happening in the mouth, they will need to be attended to by a dental person. But they're not covered explicitly. The Gazette notice is out as of last week. Go word for word, full stop by full stop, and look and see that they're not dental benefits. And persons must procure separate covers to supplement for the deficits of the cover. Right. That's very tragic.
So that, considering
that.
So we are talking about an out-of-pocket expenditure crisis.
Yes. Whatever they are trying to cure by UHC is to control out-of-pocket expenditure holistically. It's a good thing because it's a UN agenda. And you have the deadline of 2030 to have fulfilled that spirit worldwide. And you want to show that we've been actually working towards it. But as much as you're doing this, you have diabetes, you have hypertension. The body is full of many things. And you cannot pick and say this is not important, that is not important. Because the body, as per universal health coverage, is at least to be cushioned to at least a basic care package, whereby some of the issues that are very emergent get resolved. Mm-hmm. So that is very distressing when you see that the cover provides items that are not very available and that you still have to go out of pocket and procure a separate cover. Again, to make the matters very worse, the persons who are most affected by dental issues are the persons in the low socioeconomic sector. When they delay to go to see the dentist, their issues spiral into a crisis. They have no money to buy a separate cover. Mm-hmm. Now they'll come as emergencies to the system.
Okay.
And they will overwhelm the system.
Thank you.
So we need to have a cure to that issue.
Dr. Nyekala, I want us to hear from the chairperson of the Council of Governors, who as well doubles up as the governor representing or heading the county of Kirinyaga, Anne Waiguru. And here's what she said when the governors expressed their concerns about what the government intends to roll out on the 1st of October.
Thank you, Excellency. And also, they may need to involve the county governments a little bit more in this, because this is a health function. I think also there's a disconnect because sometimes we seem to be working in silos. The indigents, Your Excellency, reside in counties, and therefore county governments are best placed to identify them. We are also proposing in our recommendation that the county governments identify the indigents. The payment of indigents is factored in the national government budget. And then, Your Excellency, to support public health facilities, it is also important that all indigents paid by both the county governments and the national should be capitated in public health facilities so that that money does not go to the private sector.
Dr. Nyikal, coming to you. Let's walk through this because we have a lot to chew here on the show. Because a county like Mombasa 001 owes NHIF close to 15 billion. Deductions are made, but you realize there is always the money that is not remitted to NHIF. And in total, this transition will be happening with more than 22 billion Kenya shillings that's owed to NHIF. Given what you have talked about and the governor there expressing concerns, I mean, when deductions are made, then the remitting as well should be swift. But that hasn't happened under NHIF given the circumstances that we are talking about here. Have these issues been substantively addressed before we transition, being a member of the Health Committee and a stakeholder who has made his contributions?
I think they have been mentioned, they have been talked about, but I have not seen clear systems, and we have asked what are the clear systems of making sure that those who deduct these monies actually remit them. And yet, in any case, that is actually the largest portion of the money that SHA will have, that NHI have, because these are readily accessible payers, because it is done through the payroll. So even that is actually a problem on its own. And you heard the governor was saying, and that's what I said earlier, the largest component of the health services are actually provided by the county government.
So we are talking about level 2 and 3.
2, 3,
and
4, 5. The only thing that the national government actually does is referral services at level 6.
So a bulk of the people to be served in the counties?
The bulk of the people are in the counties.
Okay.
And I've seen the chair of the health committee of the Council of Governors, Governor Njuki. He's been in this, but as Governor Waiguru was saying, they say they don't get real connection, some lack of serious consultation. In fact, the people who should, in my view, be driving this is actually the county government, which are saying, we are ready, we can provide the services, and therefore you pay. So the government should, the national government should actually be just talking about payment systems, collection and payment systems. Even this, the benefit packages, I don't know how much consultation was there between the national government and the county governments. Even then they should know what are the benefit packages, because the people who are going to offer these benefit packages are the counties. We actually had a presentation about it came as a tariff, but a tariff is actually the cost of a benefit package. You have a benefit package first, then you say this is what it costs. That's what a tariff is about. But I'm actually a bit surprised, and I'm going to look, that the whole area of dental services are not covered. Because I thought that the usual dental issues should be covered, but unless you come to things like dental prostheses that are expensive. Ordinarily, that you may say should be excluded, but even some basic ones need to be there. So that you brought to my attention, and we're actually going to look at that, because if that is missing, then it has to be hurriedly put in. So then the issue of the indigents the governor was talking about. Again, you know, we have nationally we have a problem of handling a devolution. because a lot of functions that are at the national level, to a large extent, are actually delivered at the county. If you are identifying who are not able to pay, I don't want us to go to the proxy means testing that has given a problem in education. Then the people at the county are nearest. But again, that service is still being done. There's an argument that the counties are not very efficient with these things. But again, it should be done. But even the community health promoters, who would also be very important in actually identifying the indigents, they are being paid in two ways. The part of their pay comes from the national government, and part of it comes from the county government. We have actually recommended in the health committee that they should move fast and harmonize this, even if you have to give that money to the counties as a conditional grant, so that they have one pay. So we are now dealing with an issue as we are going in. What is our linkage and harmonization process between the national government and the county government? Okay. So that is important. Yeah. So as we talk, we actually are seeing a lot more of what needs to be done than what has been done. And even in the committee, every time we meet, we say we think this should be done. Like the benefit package, when we looked at the tariffs, our comment was that you need to look at this. The other areas we were not happy with, but to say that a whole dental area was not covered, that we are going to look at. Yeah, Dr.
Mundia, here's the thing, because financing is a key driver of this new entire project. I'm looking at the appropriations meant for example, primary health care, and that is level 2 and 3. And this is where the majority of the public is, given the proximity to this, the close proximity to these facilities. And in the appropriations bill signed into law by the president recently, only 4.1 billion was allocated. The intended amount was 50 billion Kenya shillings. Now you are making a big leap where there's already a deficit of more than 46 billion Kenya shillings. And financing is a key component to this. I mean, you've talked about readiness, but how will the financial problems, again, be another entire horizon for the government, given that it's billing this as a key project by the state? But again, you have chronic underfunding to a very critical component of this healthcare scheme that it's planning to roll out.
Thank you. Well, what I know is that whatever project we're dealing with, UHC, I'd qualify it and give an example that it's like a four-wheel vehicle. Earlier on, we had talked about HR. That's like one of the vehicles. You have financing, the other vehicle. You have the drugs and equipment, another wheel. And then you have the leadership component on it. So that vehicle moves. But if one of the components is not available, is not adequately resourced, that means the vehicle will not go anywhere. Now that 4.1 has been allocated, and which is supposed to be ideally the different kinds of models that could be used. Look at the system at the UK, the NHS system. The hospitals are supported to run those functions. In Kenya, we have devolution in county governments. But we're having SHA now collecting this money and saying they are going to be the gatekeepers of this money for primary health care to be afforded to the people. So it's a kind of a lot of gatekeeping when the services are supposed to be felt and experienced at the county level. So levels 2, 1, 2, 3, all the way up to 4. If the system of devolution was to work, that money that is going from in that primary healthcare fund ideally should have gone to where it's supposed to be, at the mashinani, to cushion those facilities. And that spirit of free care access can be readily supervised at the grassroots. But for now, we have gatekeepers who have used that money. They're going to probably apportion it at whatever rate they want and frustrate the issues of service delivery. Now, the fund has different categories. You have that PHC fund, and you have the SHIF fund, and you have the emergency fund. The emergency fund is in the is envisioned in the Constitution. But since 2010, we have never set aside emergency funds. It came up in the Health Act. It was never operationalized because the Treasury never created that fund. And now is the time that we've thought, 14 years later, let's put some money for emergency care. That could have always existed with or without SHA, or even without NHIF. And NHIF was principally for the employed people. And over time, NHIF mutated to become a national public health insurance service. See, public health insurance. It's like an entity that can be compared to private health insurance. And now the spirit of social health insurance is a good thing. But that is supposed to be felt either at the county level or a different project, just like the way you have the social welfare programs for the persons who are not able to make an income, where you have that social support, they get that minimum wage, like 6,000 contributions per month, amount payment per month. So this project, the way, in my opinion, the way it's envisioned, it's running, it's a good idea.
Okay.
But the operationalization is not working. Again, there is lack of prudence of use of public money. Lack of prudence, I would emphasize. Reason being, you've heard the court say that these laws were unconstitutional. And the laws being unconstitutional, when you put investments that are very heavy on an unconstitutional thing, you are not going to recover that money. That is money that will be lost if eventually everything is declared unconstitutional. The court said there was not enough public participation. We've been in this country for the last 14 years. And when public participation is deficient, there is no way to cure it. Okay. And you cannot cure it after the law has been made, because the law is already sailing. So that means now we're likely to have situations whereby the law is created, we start panel beating situations to move somewhere. So where we are, in my view, there's a lot that needs to be done. The county governments have not been supported adequately. The funds coming in from the treasury to the SHA, they're not adequate in the different...
But Dr. all counties are capitated. You agree with me?
Yes, capitation...
Yeah, because there's also a governance issue here we have to talk about, despite the decry expressed by the Council of Governors. And this is an accountability issue as well. Because in as much as we have talked about the finances, we have to be also... we have to question cases where the countries get capitated, but there's no value for the money. For example, allow me to ask you this. How is it that NHIF perfectly worked for Murang'a County and some counties were struggling? Isn't it just a matter of leadership? Because many of these counties open bank accounts for every single dispensary that's there in the county, instead of one NHIF account that ought to be running the affairs. So it's a governance problem at both levels. You agree with me?
See, whatever you've said, there are many issues you've said on that point. Many. First of all, you can run healthcare like a small business and be very efficient. This is what a governor is supposed to do. Make sure the drugs are available, the doctors are available, and there is no funds leakage at that point. That system runs efficient. And because now patients are satisfied, they keep coming and you keep making more, and you're able to have services satisfactory. That is what is probably happening at Murang'a. Now, places where that is not happening is probably funds leakage. That's now an issue at the small level of how the operations are running. Now, come out from there, go now to SHA. SHA is supposed to pay for services that have been rendered under capitation or fee for service. Now, capitation, they say after 3 months, either. Now, the proposal is to pay after the period, while it's supposed to be pay before the period, because I'm now able to equip the drugs and I'm able to run. But now it means I'll have to use good money, like lend in advance, and wait for government to reimburse me after the end of the quota period. That's a proposal. Now, that's capitation model. Fee for service now is whereby you're like going to the supermarket, picking a service.
You pay for it.
Have a form, approve for the service, and then after 35 or 45 days, the payment will come for that particular service that was procured. So that happens. So when the fee for services are not paid for in good time, the hospitals incur a lot of credit. And that's where the county government and the private hospitals have been saying they have not been paid. And for that reason, the old debts should be paid before in transition to the new future. Because if the debts are too huge, that means a lot of persons will be left in difficulties. And then pay them again at the end of the quarter, more difficulties. It's a lot of disgruntlement. That means very few people will make investments in the sector. And that means frustrations when patients come to the facility, they don't find drugs. They only find the doctors, but they're not drugs. They keep on saying no. Then they'll have to go to the private facilities. And the private facilities probably also having the same issues. So patients will feel frustrated. So it's an ecosystem that needs to function in many
service personnel ways. Problem. Dr. Pukose, good morning.
Good morning.
Lovely having you here on the broadcast.
Thank you.
Thank you. He's the chairperson of the National Assembly's Health Committee and as well the representative of the people of Endebess constituency. And thanks for your time. In 6 days' time, I'm sure you will be very key as the rollout begins. Are we ready?
That's the big question. Because the ministry has told us that they are ready to roll out the program. And I think on Monday, we'll be having a meeting with the ministry because we want to know from them the preparations which they have put in place to make sure that this program is rolled out seamlessly. We know that they have been simulating some of the activities like how to onboard members into the system. They've also told us that so far you have close to almost 2 million people who have registered into the system. But we know that we want almost every Kenyan to be in the system. Mm-hmm. So I think between now and that time, we expect that the ministry is able to continue pushing so that many Kenyans are able to register and be able to access the service. The challenge would be if not everybody is on system and the people they become sick and they need to be attended to and you are not in the system. So you find that you now need to register that person and that person needs to access the services. So I think it's running against time to make sure that we are able to deliver. But from our side as oversight team, we'll make sure that we do proper oversight to make sure that the ministry is able to deliver. You know, they are the ones who are the implementers. We are not the implementers, we are the oversight body. And therefore, we will hold them accountable to make sure that the services are delivered to Kenyans.
And Dr. we have just a case here. I'll come to Dr. Nyekal. My producer had registered. He's been told to wait for 3 days for the biometrics. So it's not a one-day affair. So you have 6 days from today to register more than 49 million Kenyans. Because what we have now is slightly over 1 million Kenyans who have registered. And the criteria is you get service when you get registered under this scheme.
Yes.
So is that possible? It looks like it's mission impossible.
Initially, NHIF had a system that is in place, which is a system that has been working. The ministry has been so reluctant to push out this system of NHIF that has been working. And I think from where we sit as a committee, the ministry should be able to, if you want this system to work, then you have a system that has been working in place. Why do you need to discard it? Use that system that has been working, make sure that it brings on board all the people who have been registered, because it's a system that has been working. Then gradually, if you want to bring in another system, you do it gradually and make sure that that system is working. So NHIF had a system that was working, and the ministry wants to push that one out and leave it. So that's the irony of it all. The ministry should be able to take up the system that has been working in NHIF, use it, because if you find that people are not going to be, that this other one is not going to, it is going to take time.
Yes.
Yeah. And even for record purposes, yes, the ministry has not been able to clearly explain to the committee this other system, how does it work? Because they tried to go and simulate it in Marsabit, it failed.
Okay.
They've tried to go to Tharaka Nithi to simulate it to see if it is able to work. So far, I don't think we have very good results.
Yeah.
So I think people must own up and take responsibility.
Okay. Thank you. Okay, just a minute. I'll give Dr. Nyekal the time. But first, Dr. Nyekal, I'm sure you are nodding your head, certainly not in agreement. But let's hear from the head of state, the president, who has touted this entire mission as very key in the country's healthcare system, billing it as very big in terms of the impact it will bring and the burden it will lift off the shoulders of many Kenyans in accessing healthcare that's affordable and quality.
If we can solve this question of health, then we will have solved one of the very big problems we've always had as a country. All of you remember that the many Harambes we used to hold in the past, what we did around education, that problem has, there are no more Harambes anymore about school fees. They are very, very exceptional situations. The only problem that we still have is Harambes around matters health. And that is why it is important for us to solve this health puzzle. And it requires the concerted effort of all of us. I remember very clearly asking Mahmoud here to be the chair of NHIF because I wanted to do some work around it. And he did a wonderful job in NHIF. But we couldn't get it quite to the place where we wanted it to be. And learning from the experiences of what we did in a Grand Coalition government, what we did as the Jubilee administration, we've gathered a body of experience on how not to do it. You know, they say, when somebody tries to do something, if he succeeds, he achieves what he's doing. If he fails, at least he has one lesson, how not to do it.
Dr. Nyekal.
The president is a vision holder. So the president is telling the country what he wants done, the vision he has for the country. It then comes on the vision implementers. That is the ministry. And actually, you're saying I was actually nodding in agreement with my chair.
Yeah.
Because he is telling you that the ministry has been reluctant, and I was telling you that we have been telling them, that's what I said before, we have been telling them that this is, we think, the way to go. And this, when he says reluctant, he means we are not seeing as a committee whether they're as ready as they are saying. That I think we agree on. So when the president says that is the ideal, now you're going to implement it, we are going to change. Let me tell you what's going to happen. I think the problem we have here is the definition of what the launch is.
Yeah.
I don't think the launch will get us that on second, after first, everything will be sure. From what you have said, from the figures,
yes,
that alone is not possible. My colleague has said there's a system that is working in NHIF. That system is going to force itself on us, whether we like it or not. On second, people will go to hospital and then they say, I'm not registered in in SHA, but I'm registered in NHIF. Are you going to throw that person away and say we are not going to give you service? What is going to happen? This is what they'll do. Whether they like it or not, they'll say, tell us what your NHIF data was. They'll still be able to check it and find out, okay, we can service you, but now you need to transfer. So what we are going to do in my way, we are going to move to SHA rather rapidly from NHIF. This will force us to shift. So the launch, what I'm seeing to be launched, is the beginning of the operationalization of SHA, not a shift. It's the beginning. And whether we like it or not, it is going to be gradual. Do you think somebody who can tell you as a card, and I've been working, and I'm sick, and I'm in hospital, and now you are saying, now you are not registered, go home? My chair will tell you, we won't allow it.
That one should not.
We won't allow it. So what we'll then say is, okay, give us the details. And I think they'll have to work out, this system will work out. And when we meet on Monday, we're actually going to insist. And we'll just give an example. Tell us this person who has come, has got an old card, and now is not registered.
Yes.
The registration will start. So it will work. So I say that the big thing is how we talk of what is going to be launched on first. Mine is the beginning of the operationalization
Yes.
of SHA.
Yes.
And we were talking about primary health care and the primary health care fund and the emergency fund earlier. This, particularly the emergency fund, this, as actually said, is in the Constitution, Article 43, literally almost says emergency will be taken care of, and people who cannot afford will be taken care of.
Yeah.
That is in Article 43.
Mm-hmm.
In Health Act 2017, actually we worked on it. It actually created the ministry should create an emergency fund. Now it has been created. So, but that is, the fund is going to come from tax, as I said earlier. So I don't think it will be funded to the maximum.
Yeah.
It will, some money will go in and it will start working.
Okay, and
again, I'm
Dr.
saying...
I point this out, hold on, Dr. Mundia, because let's give a breakdown of then what happens after the deductions. First, that deduction is coming from marginalized 3 million Kenyans who have filed their returns with the Kenya Revenue Authority and per the Kenya National Bureau of Statistics. So we are not even touching the informal sector, because I want us to come to the means testing as well. Second is then the money hits the SHA bank account. And Dr. Pukose and Dr. Nyikal, you agree with me that appropriations are done by Parliament, where you sit. Then here it will come to the CS National Treasury and Economic Planning regarding the release of the emergency and critical funding that you have talked about. Will this not lead to unnecessary delays here? And then what will happen to the person who needs dialysis, who was on chemotherapy, and who may need emergency attendance at a medical facility?
You have no option. That is the only way it is going to work. What has been designed is that it is funded from the taxpayer. So like all other things, in fact, I think in the budget, we actually did put some money for the primary health care and for the emergency. Parliament will do that, and Parliament has done that. I don't think it came to what we wanted. You are talking of 4 billion.
Yes.
But what we would have wanted was more. That's what we put. It will be collected, it will come to SHA, and SHA will then have to now work system. And they have not shown us, my chair is here,
yes.
They have not shown us exactly how the emergency fund will be paid when a patient has been seen on emergency basis.
Exactly.
There has been an indication on when it is chronic illness, when now you can't get the SHIF services, this kicks in. That's why I'm saying this launch is the beginning of operationalization. Everything is not going to work at once. The one of primary health care will be capitation, which means some amount will be allocated and will be given. Once again, and we'll say this up to time, and my chair is here, we don't see how at this moment in time they are going to move that money, and on Monday we'll expect that those should be given. So what is worrying people most is SHIF, NHIF.
Yes.
Now the SHIF, I've told you in my view, whether they like it or not, there'll be something gradual about it.
Thank you. Yes, Dr. Mundi.
Thank you so much. I want to agree with the President on some of the statements that he makes, that anyone who does not change their mind is a fool. And he constantly says that, which is a very good statement. When you realize you've made a mistake, you're allowed to change your mind. And today I'm happy that my colleagues, Dr. Pukose and Dr. Nyikal, I'm a lawyer and a doctor as well. When the law is not working, on legal engineering, you're supposed to re-engineer the work and see how it works in your favor. I've also appreciated that they both see that whatever we are going at is good. But the implementation part, if it is not going to work out, that means the NHIF system probably never had any issues. And now we want to discard that. Article 10, accountability and prudence of use of public resources. We cannot project to spend a lot of Kenyan money that is hard coming on a new system when the system that is working, on a law that was probably working, because no one probably said that the NHIF law was not working. Now the good thing of the clause, social health insurance, that is a good thing. It's a clause that could have been added in the NHIF Act and be operationalized under a section of the law. with the spirit of primary health care. And the delivery of the vision of the president of UHC would still have been achieved without a lot of expenses, without a lot of branding, without a lot of marketing, without a lot of many things. Now, we hear there were ghost persons in the system. You can always self-validate persons in a database and tell them, verify whether you're already existing, and if you're not, you're going to be ejected. So the ghost persons, the way you do a head count, if they don't show up, you eliminate them from the system. But now we're told a new system has to be put in place so that you can now weed out ghost people at a very high cost, prorated for 10 years, amortized. The system is not even ready. It's not even piloted. You even wonder what is this rush to. Now, the implementers, I would say that is where the problem is. Because they probably don't understand the context of usability, the patient factor, the president's vision, and achievement of UHC. UHC means universal healthcare coverage. At least a basic care for a majority of the populations are not able to access that.
All right.
That can be delivered through the county government and through the primary healthcare function, which is already in the Constitution, Schedule 4.
Thank you.
So the aspect of SHA has to come. SHA has only brought tribunals. That's the only thing that SHA has brought. Because biometrics and digitalization was there, registration was there, services was there, capitation was there, empanelment was there, contributions was there. So what has SHA brought other than the letter S to NHIF? To just change the letter alphabet.
Yes.
It's not proper.
Yes, Dr. Pukose.
It's not proper.
Thank you. Listening to the president has a vision for the country. And when the president was campaigning with us, one of the things he promised was to make sure that the healthcare issue is addressed. And we've had the President Kibaki, President Uhuru attempt to bring in UHC. And both of them have not been able to be successful. Even the pilot that was carried out in Nyeri, Machakos, Kisumu, it never succeeded. Now that is where he says we've learned the mistakes that have been done, and that is how he came up with the government having sponsored the 4 bills: digital health, social health insurance, primary health care, and FIF bills. Now, having put these laws in place, the president expects the people he has given jobs to do the right thing. And that is where now, when we come to issues about moving from NHIF to SHA, it is going to be a gradual process. It's not going to be just a one-off transition. It's going to take place. My colleague here is saying that the only thing maybe SHA brought is social. But you remember, we did not have emergency, chronic, and critical illness fund. We've never had. This is the chronic and critical illness fund. We've never had. This is the first time we're having it. We did not have the issue about primary health care fund. We did not have community health promoters in the initial stage, where they are empowered and given equipment to be able to do their work. This is the first time this is all done. But it is now those who are in the position of implementing to make sure that this is done properly and to the satisfaction of Kenyans. I think that is where we should be able to.
And Dr. Pukose, how comes it then escaped the attention of the policy players and the president as well? Because he talked about the vision he has, and I earlier on did put this to Dr. Nyekala and Dr. Mundia. The appropriations bill signed into law allocated only 4.1 billion to primary healthcare. That's level 2 and 3, where a majority or a bulk of the population is. For a majority in the country who can't access medical care and who can't afford that as well, instead of the earlier proposed 50 billion, how will 4.1 billion then help these facilities that are at the bottom pyramid of the healthcare structure, where a majority of Kenyans go and seek healthcare services and in most cases can't pay?
You know, level 2, level and level 3 facilities, and possibly level 1.
Yeah.
One, we have the FIF fund. which is whatever they are going to generate from that facility, it should be able to be protected and go back to those facilities. 2, at that level, if you are engaged, you have a chronic illness or a critical care or an emergency, you should be able to be taken care through the emergency, critical, and chronic illness fund. So it is not that, and this is the first time you are starting with this fund. This is a seed money. We are not saying this is what we even don't know how much. You know, those are estimates. People have sat down, done estimates, and say maybe we could be able to use 50 billion. The government has decided, let's give a seed money of 4 billion, to start us off. But you should not forget that we have the FIF fund. Whatever is collected within those facilities now is protected, because initially what is collected in the health center or the dispensary was going to a central fund in the county, and that money would not be able to go back there. 2, in addition to the FIF fund, you have the county allocation, what is allocated to the counties. Whatever is allocated to the counties, the county assemblies will appropriate a certain amount to those health facilities. So you still have some money that it's not clearly captured in that estimate that is being done, because you have what is appropriated by the county assemblies to level 2, level 3. You have what is collected, that is the FIF money, that is money which is collected for the services, and now you have a fund which is also going to take care of that. So it is not completely that you need now to have that money already in that fund to be able to provide the services.
Yeah, and here the capacities are different, you agree with me, of the facilities, is it? Because in Nairobi alone we had 22 facilities that were not functional. We had 13 in Meru, 17 in Kisii. That then explains why Mama Lucy in Nairobi is overcrowded with people seeking healthcare facilities. Is it? Then is the capacity aspect here factored in?
You know the issue about employment in that is the human resource. That's a county function, because these are facilities within the county functions. And when you come to employment, it is not, that money is not part of that, because it is the county, the county public service board that will now employ the workers who are to be in those health facilities. What the national government is only doing is they are sharing the costs for the primary healthcare promoters. That is the only one which they are sharing, where they are giving them a stipend of national government giving 2,500, county government giving 2,500. And as a committee, we've actually been very firm on the national government to make sure that they meet their side of the obligations.
Okay. And Dr. Pukosi, still on you, before we sample the feedback, being biased towards you because of the little time that you have been on the show, to be fair to you. One other issue that is of concern is the means testing. And here you have a website where that is the SHA website, where you key in, then in case you state the vehicles you own, what you have at your household, for example, say a flat screen that is 70 inches, Samsung model, assuming. Then you have a Mercedes-Benz, then you have a refrigerator, LG/Samsung, let's say that. Then your premium shoots up. And here you have the risks. What are the risks here of then people doing an under-declaration of what they own? Second, the case of your old man in Endebe's constituency, assuming your dad, or my old dad in Wajir County, or Dr. Nyikal's kin in Kisumu County, who may not be in a position and are literate enough to key in those stuff, that key information. What happens to them? Who is there to help them? I mean, these are very two key issues that still are unaddressed 6 days before this rollout.
I think that's an area that is a little bit challenging, and we have to be realistic to it. We saw what happened with the means testing in the Ministry of Education for the university students, where others, instead of being put in Band 1, ended up being put in Band 4 or Band 5 by mistake, because this is something that is new within our setup. It has not been done before. So I think as time progresses, we'll face those challenges. And I think we should just prepare ourselves that there'll be challenges in terms of that, because you can assume even somebody putting up, you have an LG of that 14-inch or whatever.
Yeah.
But at the end of the day, maybe somebody even bought for you. I bought one for my mother who is in Kitalale, and she doesn't have any means of earning. Yeah. She's an old lady, around 70 years old. So you're buying for her, you build a nice house for her. That is what she has, because you cannot live in a nice house and your mother is not living in. But that is what you bought for that. So these are the challenges that we are going to face with the means testing.
Yeah.
And then we also have, I think, with the means testing, we'll also ask maybe the branches to be able to support. The community health promoters will support. The healthcare workers within the various branches. Yeah. The children, our own children who have maybe gone to school, or even your neighbor's child who has gone to school can come and assist you to be able to fit. So these are the, we shall customize it as per our own setup.
Thank you. And of course, it's an evolving conversation here. Let's sample the feedback and see what Kenyans are saying. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Babu Michael says, about SHIF and even SHA as a whole, as long as we have resolved that they are the silver bullet to healthcare problems, the controversies around it, like the Adani's involvement and the legal issues, must be made clear. Kenyans must get value for money. Samuel Owood says NHIF's weaknesses, especially for non-salaried Kenyans, have left many without adequate healthcare coverage. The shift to SHIF corrects this by introducing affordable contributions for all. Jim Rose says everything in this country is annoying. Now SHIF doesn't cover dental care and our legislators support the scheme. Why don't they, the Ministry of Health, improve the NHIF? Samuel Owoth again says fraud issues in NHIF have long plagued the system, but NHIF introduces stronger frameworks to prevent mismanagement. Sawe says NHIF had its challenges, but it was working. The government was expected to build and improve on it. So why introduce a new model that does the same thing? Is this really about improving healthcare, or is there more to it? Will SHIF work perfectly? Gentlemen, your time is appreciated. Many thanks. Of course, after October the 1st, we'll be here, two very critical members of the committee and a member of the Kenya Medical Practitioners and Dentists Union, and I want to thank you for your time. We'll talk more about the structure, what works for the Kenyan people and going forward, how this will alleviate the suffering Kenyans endure when they go to healthcare facilities and they strive towards affordable and quality healthcare. Dr. Kahura Mundia is the Deputy National Chairperson at the Kenya Medical Practitioners and Dentists Union, as well as Dr. Robert Pokose, the Chairperson of the Health Committee of the National Assembly, as well as Endabe's constituency MP, and his counterpart from Seme in the county of Kisumu, who is a member of that committee, Dr. James Nyikal. Thank you for your time, gentlemen, much appreciated. And we look forward to more engagements. Of course, we'll be calling you here to get more and at the best interest of the Kenyan public. Up next is health and lifestyle. I'll be having a discussion around cerebral palsy, and it's a discussion that you don't want to miss. Then later, we'll be talking about another discussion altogether. That's from 8:30 here on the broadcast. Stay tuned.